I have a very easy role because everything was already mentioned before by my colleagues, by Professor Haluzík and by Professor Fried. So I will skip all not necessary slides, and my talk will be really brief. I have to start with epidemiology, and you see obesity and type 2 diabetes, metabolic syndrome. It's a global problem, and for the future it will be for sure not better. We have a lot of patients who needs to be treated, and you see these patients are not from Africa, of course, and from Asia, but mostly from the rich part of the world. And of course, treat these patients is not easy and it's not cheap. And in the United States, they know this very well because it will be, and it is really good business. So the situation in 2015, you see from 11 people, one has diabetes. And these data are 3 years old. So for sure now is it not better. So I will start with a Swedish obese study. It's something like a big polyp study for endoscopists. It's something what makes really great data, and these studies shows very important information. Bariatric endoscopy is excellent. It's a powerful. It's efficient very well, and because of this study, we know also a lot of things how the surgery works and how bariatric surgery could help and could treat also diabetes. So, as you see, it was already mentioned by Professor Haluzík, the key is the incretins. The incretins, it's very important hormones, and it's the miracle of bariatric endoscopy and bariatric surgery also. You see this slide you have also already seen before. We have to talk only about the gastric bypass because the gastric bypass is the powerful and most important bariatric surgery and very strong and very good for diabetes treatment. And incretins again, GLP-1 and GIP, these two hormones are the key for the success. But you see this slide you saw before also, incretins is very powerful for different organ in the human body. But are these hormones really the only key for the success? This study shows that it's not true, and there must be something more. And the something more is also the changes in gut microbiota. It's very important. And also this slide you saw before. It's bile acids and is stimulating insulin sensitivity. And this draw by Professor Haluzík, it's my favorite because you see very easy where are the important factors for our treatment, for our action. So you see duodenum, and the ileum. You see in duodenum there are factors worsening insulin secretion, and the opposite factors improving insulin secretion in ileum. And the same slide, me and the nurses and endobarrier, because endobarrier was the first endoscopic method mimics metabolic surgery. So I have to say we had 180 patients and very good results, but because of there was a lot of data from many studies, we did our own study in ICEM in Prague together with my colleagues and with Professor Špičák, and the results were really exciting, and no side effects, no serious adverse event, no early removal because of some pain or something. So you see the changes in excess weight loss and in glycated hemoglobin. And it was, of course, because of Professor Haluzik's mentioned before, GLP-1 concentration and bile acids. So all of these things were measured during this study. So we, because of this study, know that the endobarrier was a really good idea, and it will be, after some modification, available, I think, in 6 months in Europe. And we have, of course, a lot of next or different endoscopic bariatric methods, but these methods are not metabolic. How Professor Fried mentioned before, the Apollo sutures, horizontal gastroplasty or vertical gastroplasty, it's nice, but it's only a reduction of the volume of the stomach, and only ghrelin is changing. So I think it's not enough for bariatric endoscopy. We have something like, may I ask for a switch on the video, please? So this is the Valen. It's some special sleeve which is going not to the bulb but directly to the cardia. So you bypassing not only duodenum but also the stomach, and it's a great. Unfortunately, it's not so easy method, and we have no data. I don't know really why, but I think there must be something changed, because it's really not so easy to do. But I think it's a great idea for the future. And again, the same slide. It's a very clever idea, and 10 patients were done in Czech Republic, in Ostrava, by Professor Machytka. It's pressure necrosis by the magnets and anastomosis jejuno ileal or duodeno ileal, and it was the problem. Nobody knows when this procedure was done where these magnets will be connected. And of course, this study was also with few complications and not so mild complications. So I think it's a good idea, but the better will be gastrojejunal anastomosis. I will show you later. So we also in ICEM have some study with a very easy device, Satisphere. It's just a simple wire with a few balls in the duodenum, makes some irritation and changes some hormones and prolongs satiety etc., etc. The results of 7 patients were, for me, surprisingly very good. But we have some problem. The anchoring of the system in the antrum was not sufficient, not enough, and we had 3 migration, and this one was completely down. For comparison, normal situation. And now I think something interesting for you, because everything what I'm talking was mentioned before, and it's duodenal blinding. The first device called Revita, using hot water, was, I think it's a 5 years later. And the idea of this method is to destroy the censoring system in the duodenum. It's very clever, but this method destroys only mucosa, so only sensors, and because of this principle, this method is not permanent, but the studies shows the results are good. But we are doing something different. We are using a laser, and we are targeting directly to neural cells in the submucosa. The method, the name of the method is Diagon, and I will show you. It's a picture of duodenum after the procedure. You see, I don't know how to do it. You see here the burning places, not in mucosa, but under the surface, so in the submucosa, and it's a special. It's only it can do only laser to focus the energy under the surface. So it's a very clever method. You have the balloon, you inflate the balloon, and in the middle of the balloon you have the catheter with the emitter of the laser, and you do like a rings. I will show you the video. Maybe play the video, please. So it's a view into the balloon by the scope in the duodenum. And now you will see this white line. It's a burning place, but the mostly of the energy, or the majority of the energy, is in the submucosa. So it's very important. And after the procedure, you desinflate the balloon, and you are going out with a scope with this device. So now we have 21 patients in our hospital, and the results are extremely good. And please switch on the video, please, and go to the middle of this clip. We, together with the Professor Haluzik, we will prepare the study with a pressure necrosis and magnetic anastomosis. Please, to the half of the clip, please. You see, it's a very easy. You place one magnet into the stomach and one magnet into the jejunum. Maybe can go back, please. And the video, please, once more time. And the result is very clever. So everything is going by this way, and you can do endoscopically anastomosis, gastrojejunal, without some surgery. So I think this is the future of the metabolic endoscopy. So, because metabolic endoscopy is very powerful, we have to think to prevention of bile stones formation. So as you see now, it's known that ESL had a guidelines, and also in our department, so bariatric endoscopy, we have to do the prevention of bile stone formation by the bile acids. So my conclusion, as it was before mentioned, there is, maybe go back please. The bariatric endoscopy is very powerful, and it's a future. I think it's without big risk, and I think we will, in the close future, replace a little bit or add to bariatric surgery our method. Thank you for attention.